Hi, everyone, and welcome to our very first Carolina seminar of the series Bring on the Heat. And we're so excited to have you all with us today. And today's session is going to focus on answering the question, what is menopause? So it's really an overview of the basics, and we will have a lot of other installments going forward over the next couple of years that will dive into more of the details. So if there are things that you want to know more about, please fill out the survey at the end. Kate will be sending everybody who attended a link to a survey where they can complete more information and let us know a little bit about who you are and what things you would like to hear from us going forward. So with that, I think we will get started. I'm Crystal Schiller. I'm a clinical psychologist at UNC. I'm a researcher studying how hormones impact the brain in women across the lifespan. And I help run our menopause clinic as well as do research on menopause. So with me today is Dr. Lauren Schiff, a longtime collaborator, colleague, and friend. So Lauren, do you want to introduce yourself?
Sure. Hi, everybody. I'm Lauren Schiff. I am a minimally invasive gynecologic surgeon. So I spend most of my time with women who are in the perimenopausal phase of life, looking for resolution for problems with fibroids and endometriosis and heavy bleeding, and have a particular interest in the menopausal transition and how it affects us all going through that. From both a physiologic standpoint, what you're experiencing with your periods, et cetera, but then also with mental health and how it interacts with our daily living. So I've loved working with Crystal and her team, and I'm excited to be here today.
Great.
Please excuse I might be sucking on a cough drop, so excuse me if I sound hoarse.
Time of year when everyone has colds, so we understand. I'm going to share my screen now. Okay. All right. So like I said, we're going to be talking about what is menopause today. This is funded in part by the wonderful folks at Carolina Seminars. We have a broad team of experts that are participating in our seminar series, psychiatrists, psychologists, folks that specialize in exercise and nutrition, and cognition, heart health. And so we're really excited to share our knowledge with you, and also hope for this to be an ongoing conversation such that we can also learn from you and your experiences, and find out what's important to you as we think about designing new research studies and building up our clinics. So for today, we are going to cover a few different topics. So the first question I usually get from both patients and research participants alike is, and also my friends, is how do I know if I'm transitioning to menopause? So we hope to cover that in detail today. We'll cover some common and uncommon symptoms. We'll give an overview of treatments that have been shown to work. And then we'll present some ways that you can get connected with us if you have more questions. At the end, we will have a Q&A. So as we're going along, please feel free to use the Q&A function at the bottom where you can put in any questions that you have, and then we will answer as many of them as we can at the end. So we're going to spend about half of our time today just giving you sort of a basic overview, and then we'll spend the remaining half of the time doing Q&A, because we often get more questions than what we can answer in a single session, which is great now that we have the opportunity to do some deeper dives in future sessions. I also wanted to go over disclosures. So both Lauren and I are paid by the UNC School of Medicine, and we have grant funding from the National Institutes of Health, but we are not paid by any drug companies or anyone else. So we have no sort of conflicts of interest, and wanted that to be clear at the outset today. All right. So first, I want to talk about terms. So the word perimenopause is a medical term that is used to describe the time around the final menstrual period when hormones and the reproductive system changes. Menopause is what we call that time that comes after 1 year following the final menstrual period. So you're not said to be in menopause or menopausal until a year has passed since your last period. That whole year in the interim and time leading up to that year when periods become irregular is called perimenopause. And so we're going to be using that term today, perimenopause, and I just wanted to be clear about what that means from the outset. All right, Lauren, I'm going to turn it over to you for this next part.
Sure. So one of the main things that we talk about a lot is when menopause occurs. And it ranges, but the range is pretty tight. So the age of menopause is really genetically driven. It's about 50% inherited. So if you were kind of wondering, when is this going to happen for me? If you were able to ask your own mother, when did you go through menopause? The likelihood is that you will experience similar symptoms around the same time. And we can see that it doesn't matter where you're from, what your background is, but across the world, menopause happens about the same time, ranging from around age 48 to 52. So what are the things that are associated with your timing of menopause and how long it actually, the perimenopausal period and how long it lasts and when it starts? So some women experience a pretty short period that we would consider perimenopause, where they're experiencing possibly hot flashes or mood changes, and we'll go through all of that in more detail, and then have that period of a year without a period that Crystal was just talking about. And some women experience that for a much longer time. There are some factors that are associated with those differences. African-American women tend to have an earlier onset and a longer duration of that perimenopausal time until they reach that 1 year of no period. Similarly, smoking is actually associated with an earlier onset, but a shorter duration. And obesity is associated with a later onset. And that has to do with the fact that fat cells actually produce estrogen. And so we think that the estrogen produced by those fat cells actually keep your estrogen levels higher for longer and lead to a later onset of perimenopause.
And the reason I think this is so important to include here is we ran a focus group with African-American women recently who said that when they started having hot flashes and some menopause symptoms, their doctors were really dismissive of them because they were in their early 40s. And their doctor said, well, you're too young to be experiencing menopause. And so in my opinion, knowledge is power, and I want people to be armed with this information because a lot of physicians don't know all of these things. So, all right. Lauren, if you want to keep going, you're welcome to.
Sure, I'll go and then I'll pass it back to you. Okay. So what is actually the cause of menopause? So if you look at the bottom of this diagram, it shows a schematic of your uterus and then your ovaries. So the reason we have a period is because your ovaries are producing estrogen throughout the month, in the beginning part of the month, and then that estrogen level drops off. And when that estrogen, what it's doing throughout that period of time that it's higher is it's building up the lining of the uterus, which is what we shed off and bleed when that estrogen level drops. So you can imagine we're building all of this tissue because all this estrogen is around, and then the estrogen level drops away. And in the absence of that high estrogen level, you start to have your period. Well, this is all triggered by what's going on in your brain. And you have a organ inside your brain called the hypothalamus, an area of the brain, the hypothalamus, that actually produces a hormone that signals another area in your brain called the pituitary, that then produces another hormone that actually speaks to the ovaries and tells them you should be producing estrogen now, or you shouldn't be producing estrogen now. It's also producing another hormone, and the two main hormones in women are progesterone and estrogen. And progesterone is another important part of our cycle that keeps the balance of the tissue and the lining normal, and also has an impact on our mood. So when the ovaries start to release eggs less often, your brain thinks it needs to increase that estrogen level, so it starts sending signals more frequently. And what we see in that reflected is changes in your hormone levels here, the LH and the FSH levels we can see. And we can also see that later on in your estrogen levels. But eventually, with women, in women, we only have a certain amount of eggs that you're born with, and over time you ovulate them. And as you get older, the fewer eggs that are available left to ovulate, you release less eggs. And this is how that cycle begins of the perimenopausal period. Do you want to do this one, Crystal? Crystal, I think you're muted.
Thank you. You'd think I would have figured this out by this stage of using Zoom, but mistakes still happen. All right, so this is a kind of complicated schematic, the details of which are not that important, but I wanted to show you how experts in menopause diagnose menopause and try to figure out where a person is at in relation to that final menstrual period. So this was a schematic that was developed by the Stages of Reproductive Aging workshop, which was comprised of reproductive endocrinologists and OBGYNs. So menopause, as I mentioned, is determined by the final menstrual period. So here is the spot in the diagram where the final menstrual period happens. And the only way to know whether you've entered menopause is if you haven't had a period for the last year. And perimenopause, so entering this menopause transition, perimenopause, is determined by the length of your menstrual cycle. So you're in early perimenopause if you have inconsistent or irregular menstrual cycles. So they come either 7 days earlier or 7 days later or more than what they used to do. And then you're in late perimenopause after you haven't had a period for at least 60 days. And then after you've gone a full year without a period, then you've hit menopause. So there are some of those other hormones that we mentioned in the previous slide listed here, but those are not diagnostic of menopause, and I'll explain why here in just a second. So
I just wanted to add one little thing in here. So as you see, the definition of that perimenopausal is the changing of your menstrual cycle, but a lot of you are going to be taking medications, potentially birth control for actual birth control purposes. Some are using it for menstrual control because of heavy bleeding or history of painful bleeding. And that's going to alter what this looks like for you. Similarly, women who've had a hysterectomy, so your uterus was removed for some other reason, don't have this signaling to tell you where you are in that transition. And so we'll talk a little bit more about that later.
Yeah. All right. So for people with a uterus and ovaries, we don't recommend using hormones to determine whether or not you're peri or post-menopausal because there's no reliable diagnostic tests that exist. So one of those hormones that gets ramped up, if we go back to this slide, one of those hormones that gets ramped up, follicle stimulating hormone, as the number of eggs in the ovaries decrease, remember the brain is sending the signal, secrete more estrogen, and it does that through this hormone called follicle stimulating hormone. And so if you look at follicle stimulating hormone levels that are circulating in the body over time in years around that final menstrual period, you can see that hormone level is low up until we start getting close to the final menstrual period. Then it goes up a lot, and then it stays high and constant in the years after the final menstrual period. And so initially it was thought, well, this is a great diagnostic test that we could use to determine whether someone's entering menopause. But if you look at this on a more granular level, day to day, what we see is this. So this is follicle stimulating hormone in one person, measured every single day over time. This person was perimenopausal, so they weren't having regular menstrual cycles anymore. They were transitioning to menopause. But over the course of this 180-day trial, their follicle stimulating hormone level would have been over the cutoff point on only one day. And that's because there's tons of variability here day to day. And so if you caught this person on the wrong day, then, or on any other day except that one day, you would have said that they're not perimenopausal. And so this is essentially mostly useless information during the perimenopause. Okay, so one question we get a lot is about whether we should be testing hormones. And there are lots of folks out there claiming to be experts in menopause and its management, and they will offer to test your hormones. They may offer to test your hormones every day, or they may offer to do, expensive testing of not only follicle stimulating hormone, but lots of other things as well. And this, because of the graphs I just showed you, is not only unnecessary, but it gets to be pretty expensive. So this is estrogen and this is progesterone, and you can see there's tons of variability day to day in all of those hormones. And so unless you're going to test every single day over a long period of time, if you're just taking one day or a couple of days, that snapshot in time is going to be pretty much useless. Likewise, testing the balance between estrogen and progesterone is unnecessary. The treatments that we're going to be describing today that have been shown scientifically to work are not based on what's known on the internet as hormone dominance. That's not a thing that has been shown to mean anything in the scientific literature. And trust me, we've all looked for it. So these tests provide little relevant information in most cases. So except that, in cases like what Lauren was describing, if you do not have a uterus, then it's impossible to know if your menstrual cycle is becoming irregular. And in those cases, some testing of hormones may be helpful, especially if you have symptoms that are concerning and you're trying to do a differential diagnosis of menopause or something else. But for people who have a uterus and are experiencing periods, then we don't recommend any other kind of testing. So next we're going to talk through common symptoms of perimenopause. So by definition, people entering perimenopause have irregular periods and are skipping periods. And in the beginning, periods can become more frequent. So I think that surprises a lot of people who think that they're going to just start skipping periods or their cycles are only going to get longer. And in fact, with many of my patients, they will experience a period and then have another one like 7 days later, which is no fun for anybody. But that's a common part of this transition. You may have heavier or lighter periods. Initially, the periods may be much heavier. Many folks have hot flashes. In fact, majority of women transitioning to menopause do have hot flashes. Vaginal atrophy is also a really common factor in menopause, which includes not only vaginal dryness, but also thinning of that vaginal tissue. Urinary urgency and pain are associated with menopause. Many people come to see us in our clinic because of memory difficulties or brain fog. Insomnia, mood changes, and weight gain are also commonly associated with menopause. So these symptoms are debilitating for many people. And I think for the last 20 years-ish, physicians have sort of been telling people that this is a normal life stage, and certainly it is. It's experienced by everyone with ovaries eventually if they live long enough to reach menopause, and that we have good treatments that can help sort of alleviate some of these symptoms. And so that's really the point of this series, to get people the facts about this stuff, because a lot of physicians were trained at a time when they were telling women, and still are, that this is just part of life and you kind of have to suck it up, and that's just not true. All right, so other symptoms of menopause that are even less talked about than the ones I just mentioned include joint pain, muscle aches, headaches, and or migraines. Some women have menstrually related migraines or hormonally related migraines that are triggered by changes in hormones. And you can imagine with those big fluctuations day to day in hormones, migraines can become much more frequent and severe during this time. Cramps and breast tenderness, fatigue, bruising more easily, pain during intercourse, heart palpitation, dry, itchy skin and eyes, vaginal dryness, reduced sex drive, and then urinary tract infections become more frequent during this time as well. So lots of fun things to look forward to if you haven't experienced them yet. But as I mentioned, that's why we're here today, because there are really good treatments for these symptoms. Oh, one other thing I wanted to mention here is that some of these symptoms overlap, obviously, with other medical conditions. And so it's important that you have a doctor that can help you differentiate between these things and do a diagnostic workup for you if you are experiencing severe symptoms like this, so that we can get to the bottom of, the best way to treat it. Okay. Lauren, do you want to talk about hot flashes?
Sure. So hot flashes, they're called vasomotor symptoms in the medical literature, but they truly feel like a hot flash. Most people describe it as a full flushing sensation that kind of spreads from the lower body up from the chest to the face. With it happening, you have this rapid rise in temperature, dilation of your blood vessels. Often women will start profusely sweating during that period, or you'll actually see a flushing in the face. It affects most people with ovaries, but not everyone experiences hot flashes. And so you may have friends or colleagues who seem to be going through this transition quite easily with not experiencing it while you're sitting there sweating in the corner. And that's pretty common to talk about. For most women, most people with ovaries, those sensations can last for 4 to 5 years, which is hard to think about, having to manage that for that long. And in some women, they can even last longer, 10 years or more. And so that can be a challenge, especially to not have a mechanism or a method to try and treat it. African-American women tend to experience the longest and most intense hot flashes compared to other racial groups. And similarly, like we were talking about earlier onset of those symptoms with a longer duration. One thing also to note is that one of the earlier signs of estrogen lowering is early morning flashes or feeling warm in the morning. So some people find kind of temperature regulation issues precede the actual true flash where you just start sweating. So finding that you used to be a cold person, now it doesn't bother you. Finding that when you get up in the morning, you're very warm when you're getting ready and getting out to your day, more so than before. And that has to do with the fact that our cortisol levels, which are a hormone of basically stress levels in our body, decreases our estrogen level, mitigates our estrogen level. So as we have a higher estrogen level in the morning, it actually decreases that level in the morning compared to our cortisol as you're starting to go through this transition. When we think about the relationship between these hot flashes and our heart, so severe and prolonged hot flashes can be associated with greater cardiovascular risk and future cardiovascular events in the future, most likely related to the vasodilation and why genetically we may be programmed to have certain kind of responses within our blood vessels. Treatment of hot flashes with estrogen can reduce that risk in younger women. And we're going to probably touch on this a little bit later, but there's been concern in prior data, years prior, that taking estrogen actually worsens your heart risk and can put you at risk for heart attacks and stroke. Well, what we know now is that risk is really in older women who haven't started that estrogen treatment early in perimenopause, but rather started several years after going through true menopause, because like all of us have a higher risk of forming atherosclerotic plaques or cholesterol buildup in our vessels as we get older. So when we look at it from the standpoint of when should we start this treatment, it's actually best to start it when you start getting those symptoms to begin with in that perimenopausal treatments, the perimenopausal phase. So let's talk a little bit about treatments that do work. Crystal, do you want to talk about a little of this and then I can cover some more?
Sure, great. So this next set of information comes from the Menopause Society. They come out with position statements periodically about the best treatments and state of evidence for treating menopause symptoms. And I'll direct you to their website today at the end so that you can look for yourself and find more information there. So hormone replacement therapy is sort of the term that has been used for a really long time. Some people don't like the word replacement and use the term hormone therapy instead. But I think it's true that, as estrogen declines, we are sort of replacing it in some ways. And so I'm sticking with these terms for today. So hormone replacement therapy, or HRT, is recommended for people who transition to menopause within the last 10 years or are younger than age 60. So the research is pretty clear that if you take hormone replacement therapy after age 60, or it's been more than 10 years since you've had a period, the risks really outweigh the benefits. But prior to that, the benefits seem to really outweigh the risks, especially for people with moderate to severe symptoms. And we can talk about what that means. It doesn't mean that you have to be having such severe symptoms that you can't function or, get out of bed. It means that you're being impacted by the symptoms day to day in a way that feels troubling to you. And HRT is the treatment that is recommended for people who still have a uterus. If you have had a hysterectomy or had your uterus removed, then you can, instead of doing combined estrogen and progesterone, which is what's in HRT, you can opt for just estrogen, so estrogen replacement therapy. Estrogen seems to be the active component that impacts or reduces the symptoms, whereas progesterone is used just to prevent the buildup of the uterine lining and prevent uterine cancer. So estrogen replacement therapy is recommended for those who meet the above criteria but do not have uterus. Okay. So hormone replacement therapy is the gold standard treatment for hot flashes. There has been research looking at different formulations, doses, and routes of administration. So there are pills and there are also patches that have been FDA approved for treatment of hot flashes. And they all seem to have really similar results. And so it's a matter of working with a physician to find what works for you. Some people have skin irritation with the patch. But other kinds of side effects are much reduced with the patch. And so, again, it's about finding what provides the most relief of symptoms and balancing that with potential side effects. Lauren, were you going to add something there?
Yeah, I was just going to note that one of the reasons we lean towards the patch in most people, although the pill is completely reasonable and good in some women, is that the patch, the way that it's absorbed into the body goes through a synthesis process, which has a decreased rate of complications related to blood clots. So blood clots in your legs or your lungs or stroke. And so if we can actually reduce that risk, obviously we're going to do that. So we like to use the patch when possible. If it's not working for you or getting a skin irritation, as long as you don't have a personal history of heart attack, heart problems, high blood pressure that's not controlled, or liver disease, then taking the pill form is completely reasonable option as well.
Great, thanks. And then as Lauren had mentioned earlier, hormone replacement therapy also has favorable effects on heart health and has been shown to reduce all-cause mortality, which means death from any cause. And so the benefits of HRT can be weighed against rare increases in risk of breast cancer and blood clots and stroke. And so I think, there are few people who, would be adversely impacted by hormone replacement therapy. And that's something to consider and talk through with your doctor to see if you have any of those particular risks.
Another thing I just wanted to mention, because it's a question that comes up a lot in the office, is the fear of the risk of breast cancer related to taking hormone replacement. And what's important to know is that breast cancer risk that has been found in the literature is really only related to use of combined progesterone and estrogen when it's been taken for a long time. So it's actually more related to length of time using it, and the types of progesterone you're taking in addition, and continuing that beyond the time of actual menopause for a significant period of time. So I always want to reassure people who come to see me that this is a completely reasonable method to use, that we're not putting you at higher risk of breast cancer in the absence of you having a personal history of breast cancer, a genetic change that puts you at risk for breast cancer, or a very strong family history of breast cancer.
Thanks, Lauren. All right, so additional recommendations from the Menopause Society based on the status of the scientific literature right now is that HRT also prevents bone loss and reduces fracture risk. And then vaginal estrogen, so like a suppository, is effective and safe for treatment of vaginal and urinary symptoms. So that vaginal atrophy that we mentioned, urinary pain and urgency, pain with sex can be improved with vaginal estrogen. And HRT is different from vaginal estrogen in that HRT has systemic effects. But for those vaginal and urinary symptoms, vaginal estrogen seems to be the preferable treatment. It has a better reduction in those particular symptoms. And you can do both. So you can do HRT and vaginal estrogen to target both sets of symptoms.
And I was just going to reinforce that too, because I have heard from some patients that their doctors told them they can't take both. And so it's important to realize is that the patch is going to be most effective for symptoms related to where estrogen impacts your brain, like brain fog, mood changes, and vasomotor symptoms, so the hot flashes. But it doesn't do as well a job necessarily completely vaginally. So it does a good job, but if you still have symptoms even after taking the systemic version, the patch or the pill, adding a vaginal estrogen can come in a pill form or a cream form, even a ring form, can be very, very helpful and very successful.
And then finally, the recommendation they came out with most recently suggests that there is no limitation in duration of HRT use. It used to be that the recommendation was the lowest dose for the shortest period of time to address symptoms. And actually, the evidence doesn't support that. Now, there have been enough studies to suggest that actually coming off of HRT is associated with increased risk of cardiovascular events and breast cancer. So that's good news. If you have good benefit with HRT, you can continue taking it as long as you'd like, and as long as you don't have any significant side effects or other problems. All right, so next I wanted to talk about bioidentical hormones. If you joined early today, you heard me ranting about this a little bit because I didn't realize that y'all could hear me. So anyway, you got my true feelings about bioidentical hormones, which is that bioidentical is a marketing term that is generally used to mean hormones that are derived from plants and are identical in chemical structure to the hormones that your body makes. But bioidentical doesn't actually mean anything medically. It's just, as I mentioned, a marketing term. So transdermal estradiol, the patch that we were just talking about, is also plant-based. It's an FDA-approved medication that is identical in chemical structure to the estradiol, the form of estrogen that is most depleted in menopause that your body makes. And other forms of estrogen replacement therapy or HRT are not bioidentical, but are highly effective and have been shown in many studies to reduce symptoms with few side effects. So I want to also talk about the difference between FDA-approved medications and hormones that are made at compounding pharmacies. So to get through the FDA approval process, as we all saw during COVID with the vaccines, it's a process. And there's a lot of scrutiny that goes into approving a medication at the FDA level. There have to be several levels of studies to ensure both the efficacy of the drug, making sure that it works, and also that it doesn't cause dangerous side effects. But at compounding pharmacies, the bioidentical hormones made there are, they've not been studied scientifically. They haven't gone through that rigorous process of making sure that they're not dangerous. They're not FDA approved, and therefore we don't recommend them. And on top of that, they're pretty expensive. So some women that come into our clinic or studies are telling us that they're spending thousands of dollars a month on these hormones at compounding pharmacies. What we've just, I hope, conveyed to you is that the FDA-approved medications are effective and safe, and they have been around for a really long time. And so most of them are really cheap because their patents ended decades ago. So you can get them and afford them pretty easily, and insurance covers them.
So one thing just to touch on that for a second too is um, you may have heard of a process of working with a physician to test your hormones frequently and then adjust how much estrogen or progesterone you're taking based on those hormone levels. And this is what use of bioidentical hormones often is. And one thing I want to just point out, as related to this is when we think back to those graphs that Crystal showed earlier of that incredible swing of our hormone levels day to day, that the adjustment of what you're taking hormonally based on those, intermittent blood tests you're taking is probably an exercise in futility because you're not actually addressing a long-term state. The state is going to continually change. And so using the FDA approved methodology that we know works because you're maintaining a hormone level that's equal at all times by using that is going to be more effective, or at least as effective without doing all this additional testing and being very expensive.
Right. Thanks. Okay, so some of you in the chat have talked about, not being a good candidate for HRT and what other treatments exist. And so we're going to cover that in some detail today and then more in future seminars as well. So we presented to you a laundry list of all the different symptoms that occur with menopause, and there are lots of different treatments that target symptom clusters. So we're going to talk about that a bit more. I think one of the most confounding things in the beginning is this menstrual irregularity and the really heavy flow that can happen. And so there are new menstrual hygiene supplies in a variety of sizes, flow levels that are available now. So not just, your standard pads and tampons, but also period underwear, and some of those newer products can be layered with pads and tampons so that it can help stem some of that really heavy flow. We, in our clinic, where I supervise a team of psychologists, also work with patients on continual self-care and prioritizing one's own needs. I think in our culture, women are sort of socialized to put ourselves last in many ways. And so this is a time to really reevaluate that and renegotiate it for yourself, to prioritize your own emotional, physical, spiritual, and other needs. And that's way, way easier said than done. It sounds simple, but it is not easy, especially after a lifetime of having done it a different way. So it can be helpful if you're struggling with this to reach out for support. And that's what we do as psychologists all the time. Also adjusting work and life schedules to allow for more regular hygiene breaks can be necessary. And then another thing that we work with our patients on is having a consistent level of exertion day to day and week to week. Some weeks are busier than others. If you have kids with activities or work schedules that change, or, just times of year, this is happens to be a very busy time of year right now. And it can be easy to fall into this trap of going and doing a lot and then having a crash afterward, where then you need to rest and recover and then return to going, and then crash, rest, and recover. And so one of the things that we work with folks on is trying to pull back a little and not go into that high level of exertion. Protect yourself a little bit so that to avoid some of those crashes. And that consistency can really be beneficial for mood, but also pain and other things that accompany the menopause transition. For hot flashes, the older medical literature called them hot flushes because it feels like a flush, and night sweats. Hormone replacement therapy, as I said, is the gold standard. Some antidepressant medications have been shown to have some positive benefit for patients. Venlafaxine is the one that's FDA approved to manage hot flashes, but more traditional SSRIs have been shown to be effective as well. There are some devices that really help. So there's a device that you can wear on your wrist called the Ember Wave that helps regulate temperature. There are mattress toppers that you can get that have cooling effects. And so finding, kind of just testing some things and finding out what works for you is really important here, though I will say that some of these devices can be kind of expensive. Cognitive behavioral therapy has been shown to reduce hot flashes and night sweats, and that's what we provide in our clinic at UNC. And then other lifestyle changes can work as well. So trying to keep the core body temperature cool, which is easier at this time of the year in North Carolina when the weather is cooler, but also wearing light, moisture-wicking pajamas, having lighter sheets, sleeping under a fan, having cool water available, using ice packs can help. There's mixed evidence on paced breathing. For some people, it really seems to help, but not for everyone. Exercise, same thing, works for some, but not all. And then reducing caffeine and alcohol intake seems to reduce hot flashes and night sweats and improve sleep. All right. I lost my screen. 1 second. Too many things popping up here. All right. So in terms of managing the genital and urinary symptoms, we talked about a little bit already using estrogen treatment in the vagina, but also lubricants and moisturizers can really help with dryness and pain. It's also a recommendation to use lubricated vaginal dilator, and you can work with a physical therapist or find exercises online for doing that on your own. And then in terms of urinary incontinence, it seems counterintuitive, but drinking more water to dilute the urine seems to improve this symptom. And then avoiding foods or beverages with high acid and caffeine content. And then Kegel exercises to strengthen the pelvic floor. Physical therapists can also be helpful in guiding people through these options.
So one thing that you may wonder about is, why do you develop the genital or the urinary symptoms? And it's actually with the lower estrogen level, as Crystal was talking about earlier, the tissue of the vagina and around the urethra where we urinate from can thin, and it becomes less bulky and less has less blood flow to it with lower estrogen levels in that tissue. And so those two things on the vaginal dryness, and sometimes people experience more pain with sex due to the tissue being less flexible. So when there's a lot of estrogen around in that tissue, it's more pliable, it's softer. When the estrogen level decreases, especially as you get further into postmenopausal time, the tissue becomes more rigid, it's not as flexible. And so adding that estrogen back and using vaginal moisturizers, of which there are many different ones on the market, can be very helpful. The stretching of tissue using the vaginal lubricated or the vaginal dilator that you use lubricated as part of that process. And with the lack of estrogen there around the urethra too, you can develop more inflammatory kind of symptoms. So increased risk for urine infection is actually present as well. There's less bulk of the tissue to kind of prevent the bacteria from climbing into your bladder. And then also the irritation of the more concentrated urine tends to increase the likelihood of the incontinence that we're talking about. And this, the kind of the integrity or the strength of the tissue. And that's that's why that happens. It can feel a little bit, why was I able to hold my pee before and all of a sudden I can't? And that you didn't do anything wrong. It's just a process of that estrogen level dropping over time.
Great. Thanks, Lauren. All right. So in terms of improving sleep, again, hormone therapy can be really helpful for this as well. In the absence of that or in combination with that, cognitive behavioral therapy can be helpful as people make these lifestyle changes. However, if you're great at doing behavior change on your own, then that is fantastic. So lifestyle changes include waking up at a consistent time every day. It's much easier to decide a wake up time than a go to sleep time because we don't really have control over when we will fall asleep, but we do have control over when we can wake up each day. So trying to wake up at a consistent time each day on weekdays and weekends can help with insomnia. Reducing stimulation in the evening, so dimming lights, reducing blue light and TV exposure, like the flashing kind of pictures on TV can send messages to your brain that it's time to wake up. And so that's why TV exposure is not recommended in the evening before bed. And then try not to doom scroll on your phone or read the news because that obviously is not a soothing or relaxing activity. So trying to find something that is calming is important. Creating dark, cool, quiet conditions for sleep sounds obvious, but as that sort of your brain's ability to regulate temperature is decreased during this time, you may find it harder to keep the room cool enough, and you may need to turn down your heat in the winter and tell everyone else in the house to wear warmer clothes because it will vastly improve your ability to sleep. And then, in cognitive behavioral therapy for insomnia, we recommend using bed for sleep and sex only and not doing other activities in the bed because you then grow to associate your bed with wakefulness. And so we want to associate the bed with sleep and, relaxation. And avoiding caffeine and alcohol, certainly in the evening. Often people do better avoiding caffeine afternoon and alcohol after 5. And then some folks do better avoiding both altogether. Again, easier said than done. All right. We've talked about reducing sexual discomfort a bit already. And this slide is incorrect. So vaginal lubricants are great. Water soluble, oil-based are fine. Just pick the ones that don't have like perfumes or alcohol in them that can be irritating. And vaginal moisturizers can improve vaginal health and elasticity. So lubricants are used prior to intercourse, whereas vaginal moisturizers can be used day to day. And again, you're looking for something without lots of fragrance or alcohol or weird chemicals in it. And then also regular painless sexual stimulation promotes blood flow, and so that can actually be beneficial. But again, it's not a matter of forcing yourself to do something with the hope that it will feel better in the long term, because that will be counterproductive. So going slowly and using lubricants can really help.
One of the other things that people often experience as their estrogen level drops is a decreased libido level. And it's one of those things that a lot of people don't talk to their doctors about, but there are some things that can help. And it's a very common experience. So what's interesting in women, I'm sure that Crystal can talk to this better than I, but there's the largest component of decreased libido in women is counteracted best by psychological approaches, basically, that are the inhibition towards sexual interaction is more at the level of the brain than it is necessarily at the level of the body. And so one of the things that we recommend to women is to spend more time in foreplay and doing things that actually increase your arousal, because in order to actually engage your brain in that process of arousal, it can take longer because your libido isn't pushing you. You're not have that internal drive to do it. So if you are trying to seek out some ways to overcome that, think about prolonging arousal, self-arousal, whatever it is that you feel like works for you, but realizing that initial time might take more work and more kind of mental processing than it did before.
Thanks, Lauren. I also want to point out that there are huge individual differences here in, desire and interest. And some women find as their sexual desire drops off that they're perfectly fine with it. So we don't mean to pathologize this. And if it feels totally great to you that this isn't part of your life anymore, that's totally fine. So just want to normalize that, like, there is a huge different range of experiences here. And, for people who are experiencing distress with this, there are things that you can do, and want to make that clear. All right. So we've got a couple questions in the Q&A also about mood and emotional symptoms. And this is my personal area of focus and want to spend a bit of time here. But our next seminar is going to do a deeper dive into some of these symptoms and treatments. So stay tuned for that. So there are a whole host of emotional symptoms that go along with the transition to menopause. And for the sake of time, the range of those symptoms, I ended up taking that slide out. But some really common ones are sadness and tearfulness, losing interest or pleasure in things that you normally enjoy. Irritability is one of the most prominent symptoms that people experience, insomnia, fatigue, and the list goes on and on. I've treated a number of patients who also began having thoughts of death and suicide during the transition to menopause. And so if that's something that you're experiencing, please know that it is concerning, but it's not uncommon. And so you are not crazy. We can actually in my lab turn those symptoms on and off with hormones, meaning that when we give people hormones or change their hormones, they begin experiencing those symptoms. And then if we can keep their hormone levels constant and low, which is the opposite of what happens during the transition to menopause, we can make those symptoms go away. And so there's a lot of individual differences again in people's responses to hormones. And so some people have a more sensitive system where anytime they have a hormone change, whether it's their menstrual cycle, pregnancy, postpartum, puberty, menopause, they experience a lot of mood symptoms. And other women on sort of the other end of the spectrum have no symptoms during times of hormone change. And we don't really understand why some women are more sensitive than others. And that's the thing that I study in my lab. So I'll give you a little snapshot of what we know about it so far. But before I do that, I want to talk about treatment. In our studies, hormone replacement therapy or estrogen replacement therapy works for people who have mood symptoms that began or got much worse during the transition to menopause. So as their periods became irregular, if they started having mood symptoms, estrogen seems to really improve those symptoms. And I'll show you a little bit more about that in a second. There have been some studies that suggest that, again, venlafaxine, that drug that has been shown to be effective for managing hot flashes, it's an antidepressant medication. It also works for mood symptoms during this time. And then there's a newer drug called venlafaxine. The brand name is Prestique. It's also been shown to reduce both hot flashes and mood symptoms. And then, of course, behavior therapy, so cognitive behavior therapy and other behavior therapies can be really helpful, and that's something that we provide at UNC. Someone in the Q&A asked, like, why wouldn't everyone just take hormones? And we talked a little bit about contraindications, so personal or family histories that may give you a little bit of pause about taking hormone replacement. But the main reason that people are not prescribed hormones or feel scared to take hormones is actually because of this study that came out in 2002, so about 20 years ago. Prior to that time, starting in 1942, many women took estrogen. Premarin was an estrogen drug that was introduced in the US market in 1942. And starting then, women started going on estrogen. By the 1960s, hormone replacement therapy, or Premarin, was the standard of care for women. So in the 1960s, almost everyone got estrogen, and there was all sorts of weird things promoting the use of estrogen back then. There were physicians who were saying that, you know, it's a miracle drug and it will make you young forever, and all women should take it so that they can stay youthful and beautiful, you know, which has its own problems, obviously. But you know, it's not a panacea. I think there are risks and benefits to taking any medication. So by the 1980s, what physicians were seeing was that there was an increased risk of uterine cancer. And so that's why progesterone, or progestin, was added to the hormone regimen, creating HRT, and that seemed to reduce the risk of uterine cancer. So then there was a big, you know, one of the most highly funded studies ever to have been completed in the history of the National Institutes of Health was the study called the Women's Health Initiative Study, where they looked at the long-term consequences of taking estrogen. They said that they were studying healthy women who were perimenopausal, and in fact, they were studying postmenopausal women who were on average over 60 years old. They had been taking hormones for an average of more than 8 years. And they issued this giant press release in 2002 and stopped the study, saying that hormone replacement therapy was associated with blood clots and stroke and breast cancer. And they issued that press release before their scientific paper was even published, so that people couldn't actually go to the data and look. And what has happened since then, and taking a closer look at the data, is that all of this has been largely debunked. Estrogen treatment in younger women, so people before the age of 60, before 10 years postmenopause, is not associated with blood clot, stroke, or breast cancer in people who are healthy at the beginning. So I think despite that, there was no big press release issued to say, oh, whoops, we got it wrong, and it actually is safe. And so for that reason, this concern about hormone replacement therapy has persisted. Many people here probably do believe that estrogen causes breast cancer, and actually there's no strong evidence to suggest that that's the case. And so I think it's important that we know the facts, that you all know this history and the facts, because your physicians may not be up to date on this new literature showing that hormones are safe. So as I said, recent research shows HRT is safe and effective for many women. We have demonstrated that the estradiol patch, or the estrogen skin patch, rapidly reduces symptoms of depression and anxiety and improves sleep. One trial showed that hormone replacement therapy can actually prevent depression in the transition to menopause, especially in women who have recently experienced stress, and post-pandemic, who hasn't recently experienced stress, and has beneficial effects on heart health, as we already talked about. I'm not going to bore you with all the details of my own research, but this is graph from one of our studies showing before and after estrogen treatment. This was just 3 weeks of estrogen treatment across symptoms. So dysphoria is the same as sadness. Ill temper is essentially irritability. Well-being, we all know what that means now because well-being is a big buzzword out there. And here the control group is in blue, and the folks who were depressed as they transition to menopause are shown in these red bars. So that pre-treatment, our folks with depression were reporting a lot of sadness. After 3 weeks of estrogen, it came way down. They were reporting more irritability than our control group. Our control group was not depressed, and that came down with estrogen treatment. And then also their levels of well-being went up. After just 3 weeks, it wasn't quite as high as our non-depressed control group, but it was trending. It continued to look like it would have gone up if we studied it for longer. So a lot of our participants experienced symptom relief after just 1 week. One way that we think that estrogen is having that impact is by reducing that day-to-day fluctuation in hormones that people are experiencing during menopause. Our work has shown that the day-to-day changes in hormones or any big fluctuation in hormones can contribute to mood symptoms in women. And so if we can reduce that variability, it seems to improve symptoms. We also looked at changes in the brain. So, and again, these graphs are really technical, but before treatment, our control group had higher levels of brain activity in the putamen, which is an area that is responsive to rewards, whereas our depressed group had lower levels of brain response to rewards. And 3 weeks of estrogen treatment erased that difference. So it corrected for that lower level of brain reactivity. All right, so we're doing more studies on this now, and we would be delighted if people wanted to take part in our study. We are trying to better understand how estrogen changes brain function, structure, and how we can learn from that to provide new and better treatments. So you can go to peepstudy.org if you're interested in learning more. We also have a midlife women's mood disorders clinic at UNC, where we work with psychiatrists and OBGYNs. And then also I have, as I mentioned, a team of psychologists who provide specialized consultations. We then also can make recommendations for managing the mood and anxiety symptoms. And we can also work with folks to do short-term, lifestyle and behavior interventions. If folks are interested on the kinds of things that we work on in therapy, I mentioned kind of learning those pacing strategies. We can work on behavioral strategies for managing hot flashes, strategies for reconnecting with meaningful activities, because a lot of times when people start feeling depressed, they have gotten disengaged from the things that matter most. We work on coping skills to regulate emotions and just manage stress more generally. And then tools to interrupt negative thoughts, specifically related to menopause symptoms. We also have a menopause clinic within OBGYN, and Dr. Schiff's clinic is in minimally invasive gynecologic surgery. And we didn't talk that much today, Lauren, about folks who experience symptoms following hysterectomy with ovary removal, but that is another focus of the work that we do together. All right. Anything else you want to add there?
No, I think that's great. And I think that a lot of people experience a combination of the symptoms related to mood, related to insomnia, brain fog. I've had a lot of people tell me they experience this, like losing words, like they can't remember things as well, have more poor recall. And these are all things that can make folks feel kind of like they're going a little bit crazy. And it's just important to recognize that these are symptoms of perimenopause. And so if you're noticing also that you're having those changes in your period, those things are linked. Like and you can feel confident that it's a good idea to go see your doctor and talk about options for treatment. And then again, those women who've already had their uterus removed or who are using a hormonal method for bleeding control or birth control, you can still experience those mental impacts, because oftentimes even with the replacement, or if you're not seeing the uterus, you're not seeing bleeding changes because your uterus is gone, you may actually still experience some of those impacts of the lower estrogen on your brain when you don't notice any other symptoms. So those are important things to recognize can be happening even in the absence of a lot of other symptoms at this time.
And next time, we'll talk more about the mood and emotional symptoms, as well as some of those cognitive symptoms and what treatments have been shown to work for both of those things. If you're interested in credible sources of information, the North American Menopause Society has a website, menopause.org, where you can find a menopause guidebook. And then there's this search function where you can type in almost anything and they'll have information about it there. And the information has been vetted by physicians and scientists. So it's not the same thing as just Googling something online. So this is a great resource. And then finally, we have more seminars coming up. On December 1st, again at noon, we'll be talking more about hormones, mood, and some of that brain fog symptoms that go along with menopause. And maybe Kate, if you can put in the chat the link so that people can just click on it, that would be helpful. And we'll also send this in the email after today, where you can fill out a survey about how we did today and also let us know what other topics you'd like us to discuss. And then we will have another seminar in January, again with Lauren Schiff and our colleague Genevieve Neal Perry, who's the chair of OBGYN at UNC and menopause expert as well. So you can visit our website to learn more. And now in the remaining time, we're going to go through some of the questions that we haven't already answered. Some of them we have. The first question I see is, how's the variability of follicle stimulating hormone and or the other hormones related to mood swings and other symptoms commonly associated with perimenopause? I think I answered that, but mood symptoms don't seem to be correlated with the fluctuating follicle stimulating hormone, but they are related to the fluctuation in estradiol, and some have shown in the fluctuation with progesterone as well. And we've shown that when you reduce that variability, it improves mood symptoms. And so for most women, it's not high levels of estrogen or low levels of estrogen or progesterone. It's more the rapidly changing levels that seem to cause mood symptoms. For those with an IUD, how does this affect the experience of determining when menopause is happening or symptom experiences? With no periods, because the IUD, I don't know about changes to my periods. So, Lauren, if a patient came to you with an IUD wondering if they were menopausal, what would you recommend?
Yeah, it's a great question. So you may not have any symptoms or any signs that you are entering into menopause or the perimenopausal period. And if so, no problem. There's nothing to do. If you are having symptoms that you're noticing, such as the mood fluctuations or changes in your memory or insomnia or things that are not just the bleeding piece because your IUD is holding off your bleeding, that would be a good reason to see either your gynecologist to talk about it, or a psychologist who specializes in perimenopause, because replacement of some hormone may actually truly help. In terms of having an IUD into menopause, there's no danger to that. So there's no reason you have to pull it out unless you're noticing that your mood symptoms are worsening and you have a reason to believe it's related to the IUD. But if you've tolerated it well before with no mood symptoms, generally speaking, we don't see a new change in relationship to progesterone and in menopause.
Next, let's see. Can you talk a bit about the effect IVF has on perimenopause and menopause? I don't know if there has been a link between IVF and symptoms with menopause, but I can tell you in our studies, we see that we put women through the hormone protocol that's really similar to IVF. And in some women, the IVF protocol provokes mood symptoms. And we see those women having similar mood symptoms in the transition to menopause. So some parts of the IVF process mimic what happens during menopause. And so if you had hot flashes, or other kinds of symptoms, mood symptoms, or insomnia during IVF, you may experience some of those same symptoms during menopause for the reasons that I recommend, or that I suggested before. So as hormone levels fluctuate in some women, that seems to provoke a lot of these symptoms. And that seems to be true over the course of one's life. And so you can think about that IVF experience as sort of predicting what menopause may be like for you. What are the thoughts on HRT for breast cancer survivors? This is a hotly debated question, I think, in the scientific community. So Lauren, what's your stance on this?
So yeah, it's very complicated. And I'll tell you that in most of the situations that I've encountered this, usually it's a conversation between the gynecologist and the oncologist who's been caring for the patient, because there are multiple different factors that affect whether or not hormone replacement therapy is a reasonable choice. One is whether or not the breast cancer was hormone sensitive. If it's a non-hormone sensitive breast cancer, using HRT can be fine, but for a lot of women, it still feels really scary. And so you may choose not to. One thing to keep in mind too is that if you do have a hormone sensitive breast cancer and you're being advised by your oncologist to not take estrogen, most often your gynecologist is not going to recommend anything against what your oncologist is recommending. So in that instance, what we would say is that most of the time, using vaginal estrogen for the vaginal symptoms related to menopause is safe. And again, that usually comes down to a discussion of whether or not at an individual level you feel okay about it. I've had a lot of patients say it just scares me to put any estrogen near my body. And that they're similarly, people who have a strong family history of breast cancer but haven't had it themselves can be fearful of taking estrogen. But again, as Crystal was noting, the data actually suggests that it can be preventative and helpful. And so we don't recommend against it unless you have a genetic predisposition to breast cancer. Hopefully that answers that question. It's a tough one. It's not easy.
I think because of all this misinformation that was out there because of the Women's Health Initiative study, like it has had a cooling effect on the research and also on physician education around estrogen and its use. And therefore, a lot of people just feel uncomfortable prescribing it, even though there is no evidence to suggest that it would be unsafe in certain situations. Is a HRT patch different from a birth control patch? Are the hormones different? No. So the HRT patch contains actually only estrogen. So it's an estradiol, which is a form of estrogen in that patch. And it's a lower dose than what you'd find in most birth control pills. And in the birth control patch, I believe most of them contain both estrogen and progesterone. And so that's the primary difference. But Lauren, you would know more about this than me.
I think that you're exactly right. The main difference between them is the level of hormone. So the hormone replacement patches have a lower level of hormone than birth control pills or a birth control patch. Like Crystal was saying, the other difference is the type of estrogen. The one that you find in most patches and pills is called ethinyl estradiol, and it's just formulated a little bit differently. But a lot of women find using either a patch, birth control patch, or pills are the right thing for them in the perimenopausal transition. It can be very effective as well if it's a safe methodology for you at that time. Reasons we would, again, because birth control pills have a known association of clot risk, blood clots in your legs or your lungs at baseline. If you are over 45 and you are overweight, significantly overweight, or have very high blood pressure that's not well controlled, or again, liver disease, we would probably recommend towards the patch, the replacement patch for controlling menopausal symptoms than a birth control pill or patch.
Thanks. Next is, I'm struggling to find the right treatment because of an elevated risk of both breast cancer and heart disease. Would you have any suggestions or insights based on research or evidence that can be helpful? I think it depends on whether you actually have a personal experience with breast cancer or heart disease versus family history, because that changes the calculus around whether hormone replacement therapy is safe. But without a personal history of either one, hormone replacement therapy is likely to be protective against heart disease and breast cancer, is my understanding. Lauren, is that?
Yeah, I would agree with that. I think that certainly for the heart disease piece of it, as long as you aren't already diagnosed with atherosclerotic disease, or have a suspicion you could have it and should get testing before starting replacement. And then in terms of the breast cancer risk and the family history, that usually is one of those things that I would strongly recommend seeing a genetic counselor about if it's a strong family history, because they can help you determine what overall your risk level would be and help you trace whether or not taking estrogen would truly be a concern. In most cases, like Crystal said, it would be protective.
Do you find that primary care doctors can generally provide good guidance on treatments, or is it recommended to consult an OBGYN specialist? I think it's highly variable. I think some family doctors or primary care physicians are well-versed in this. What I'm hearing from our patients and research participants is that a lot of them are not. But also that's true of OBGYNs as well. And so I think it's about finding the right doctor and arming yourself with information going in, knowing, the information that we went over today. All of this is going to live on our website, so you'll be able to access this video there again if you'd like. And you can look up information on the Menopause Society website, take it with you to meet with your physician. And if they say like, no, you're not a candidate for estrogen, you could ask them to better explain it, or find a doctor that will work with you based on the evidence. Because I think many people, because of that earlier Women's Health Initiative study, feel like it's too risky. And so they just have decided that they're not going to prescribe estrogen as part of their practice at all. And if you're in that situation with a physician, I would just find someone else.
100% agree.
All right. Is there a recommendation for when you should stop taking HRT? The answer to that is no. As of now, there are not recommendations for the duration that you can take hormone replacement therapy. There is no evidence to suggest that there's a certain age or length of time after which people should stop taking it. I already addressed the next question. Let's see. Okay. Oh, this is a good one. So for early perimenopause symptoms that are primarily fatigue, weight gain, joint pain, vaginal dryness, is it recommended to take the patch? So should you do HRT or birth control pills if you're in that early perimenopause?
So I think that it really depends on your personal health history. So if you have a uterus, regardless of which version you take, you're going to also have to take progesterone. So if you take a hormone replacement patch that's estrogen, which we only have estrogen patches, then you would also need to take a progesterone pill because it is protective to keep the lining of the uterus thin. Like we talked about earlier, estrogen works to increase the cells in the lining of your uterus. And we know that if we just give estrogen, and we call it unopposed estrogen, or progesterone is the opposition. If we give it alone, just the estrogen, then the lining builds up, it doesn't shed off or stay thin, and you have a higher risk of potential for uterine cancer, which clearly we want to avoid. If you use the estrogen patch and add the progesterone pill, you're good to go. Similarly, you could take a birth control pill, which has both in it already. The reason to not take a birth control pill would be things we've talked about before, like your own personal risk of blood clot in your legs or your lungs. Like if you have a personal history of clot, for instance, having uncontrolled blood pressure, having liver disease, having significantly overweight and things like that, that puts you at higher risk for complications related to a higher dose of estrogen, which is in the birth control pill.
Yep. One question here was about if you're having symptoms of menopause, but still having a monthly period, would birth control or HRT help with some of these symptoms? I think the answer to that is yes. And I encourage patients working with me to kind of think of it as an experiment. So we can guide our decisions based on the scientific literature, but we also will work together to find out what works for you. Just because it works for most people on average doesn't mean that everything will work for you. Yep. How long on average does perimenopause last? Often it's around 5 years, and for some people it can be much, much longer. As a healthcare provider, I'm seeing many women ask for Ozempic for the weight gain from menopause. What are your thoughts on that? From just a scientific perspective, hormone replacement therapy has been studied for decades, and so we know really well the safety profile and risks, whereas Ozempic is new, and I think we're finding out every day about new side effects there. Lauren, anything to add there?
I think it's kind of unknown. I don't think from an interaction standpoint, I would be concerned at this point unless new information comes out about Ozempic. But, from the standpoint of weight gain and menopause, there isn't really great evidence to show a true metabolic slowdown, but it is a clear experience of most of us going through that process. The best thing to do overall, if your doctor recommends Ozempic and it's a good option for you, I think it's fine at this point. I don't see any reason to believe it would be a complication to take it with any hormone replacement therapy. But using methods to try and mitigate weight gain seen through the menopausal transition, using regular exercise and eating healthily, which also, as Crystal mentioned, improves symptoms of menopause, is really the best way to go, initially, at least, unless you're really struggling with a significant weight gain, and there could be other causes for that too.
Right. I just have a few questions left. One is about, can we help identify medical providers who are up to date on the current research? So we'll send you our information for our clinics at UNC, where you can find us and our trainees. And we're working on building a network of other providers who are up to date on the literature, and we'll try and keep that going. But as of now, we'll send you our information. But there are folks in the community who are up to date on this as well. What is our take on black cohosh for helping hot flashes? there's actually been no evidence to suggest that it really helps. And so if you find that it helps for you, then sure, keep taking it. There's some potential risk of side effect on liver that you should watch out for. But in terms of over-the-counters, there hasn't been really anything identified that helps all that much based on scientific studies. How does HRT affect your period? It should make it less frequent and heavy, although that really depends. Anything to add there, Lauren?
Yeah, I would say if you have a completely normal uterus and normal periods, meaning regular, not super heavy, then the use of the hormone patch plus an estrogen patch plus progesterone should make it lighter and shorter for most people. I will say that the uterus is a very funny organ, and some people getting all the same treatment that we would expect to make improvements makes things worse. So I'm not going to say that it's 100%. The other thing to think about is if there's anything else going on with your uterus, like fibroids or changes in the muscle wall, which we call adenomyosis. There could be a lot of other reasons why taking additional estrogen may actually make your periods heavier, even with the use of the progesterone. So definitely something to talk to your gynecologist about.
Right. What is the cause of weight gain and body changes? This is going to be a focus of upcoming seminars. That is a question that will take us a long time to answer. And there's a lot of great stuff that our colleagues have to share with you. So we will put a pin in that till next time. But suffice it to say, there is evidence of the distribution of weight around the body that changes during menopause that can be troubling to many women. And there are potential good treatments for that in addition to lifestyle and dietary changes, which are, always very hard for people to make. And then for individuals with ADHD, is there research that suggests focus or attention problems can benefit from HRT? That's a great question. I don't think it's been very well studied. We certainly have a number of people who experience attention and focus problems during the transition to menopause for the first time. And the evidence is really mixed about whether HRT is helpful. I have a colleague who's been studying the use of stimulant medication for this symptom, and so traditional like ADHD medicines, and it seems to help a lot for folks that are experiencing those cognitive symptoms during the transition to menopause. And so it could be that a combination of HRT and stimulants could work well. Is HRT recommended for a person with type 1 diabetes? We're going to do a whole seminar on metabolism and hormones, and so stay tuned for that. In the meantime, please talk to your doctor about it, and you can also check the menopause website. So any additional questions that come in, we will make note of them and send that out, answers to those questions in our final email. But please do take time to do our survey. Kate will be sending you an email with the survey, and you can ask more of these questions there. If there were things that we didn't cover that you wished we did, we have 2 years for this seminar series. And so we are going to be able to take a deeper dive into a lot of different topics. So thank you so much for joining us today and for sticking with us for the long haul. I really appreciate it. Take good care, and we hope that this information was helpful to you all. Thanks.